Hello everyone. I welcome all of you on this online webinar arranged by PSRDA. Warm welcome to today's speaker, Dr. Netra Pathak ma'am. ज्ञानामधली एक गुंतवणूक सर्वोत्तम व्याज देऊन जाते. अशाच या गुंतवणुकीवरती आपण आता सध्या थोडंसं काम करत आहोत. थोडंसं ज्ञानार्जनाचं काम आपण पुढे वाढवत आहोत. Thanks today's sponsor, Corona Remedies. A very special thanks to Lohekar sir, Nikhil Deshmukh sir for all their efforts. Now about today's coordinator, Dr. Chandrasekhar Edge. He has done BMS from Kolhapur. He is practicing at Nare since 13 years. Best all-rounder cricket player, vice captain of PSRDA cricket team, vice captain of state level DPL team. He is a national level volleyball player. Now he is a sports secretary of GPA. I would request Dr. Kamini Hinge ma'am to say a few words. Over to you, ma'am. Dr. Kamini ma'am. Okay, now I would request Dr. Shekhar Edge sir to introduce our today's speaker. Over to you, sir.
Thank you, Dr. Vidyata ma'am. Today's our speaker, Dr. Netra Pathak ma'am, MBBS MS ENT from Government Medical College, Nagpur, practicing at Nare since last 8 years. Hello.
Hello. Good evening and welcome all of you, all PSRDA members. Very warm welcome to Dr. Netra Pathak ma'am.
Thank you.
आजचा आपला जो टॉपिक आहे तो अतिशय कॉमन आहे, कारण बरेचसे पेशंट आपल्याकडे येतच असतात की सतत शिंका येतात, डोळ्यातून पाणी येतं, सतत नाक वाहत राहतं आणि हे रिकरंटली होत असतं. तर या विषयावरती मार्गदर्शन करण्यासाठी आज आपल्याकडे डॉक्टर नेत्रा पाठक मॅडम आलेले आहेत आणि आपल्या जनरल प्रॅक्टिशनर्सला याचा नक्कीच चांगला उपयोग होईल. मी डॉक्टर शेखर एडगे सरांना विनंती करते नेत्रा पाठक मॅडमला इंट्रोड्यूस करा. Thank you. Over to Dr. Shekhar Edge sir.
Thank you, Kamini ma'am. Today's our speaker, Dr. Netra Pathak ma'am. She is MBBS and MS ENT from Government Medical College, Nagpur, running own Vedant ENT clinic since last 8 years at Nare, also Nanded Multispecialty Hospital. Overall ENT experience is 20 years. Ma'am worked as a medical officer at Primary Healthcare Raigaon, District Buldana for 1 year. Worked as a junior resident ENT department, GMCH Nagpur for 3 years. Represented MARD as a joint secretary for 1 year. Worked with Dr. M.G. Tepan from 2004 to 2007. Worked as professor in Srimati Kashibai Navle Medical College and Hospital. Organizing secretary for CME on vertigo. Live surgical workshop on endoscopic ear surgery. Live surgical workshop on salensodoscopy, fellowship in voice and larynx, Dr. Dinanath Mangeshkar Hospital, Erindau, Pune, running own Vedant clinic. Ma'am has awards, best essay awards, December 2002, November 2003, and December 2002. Best paper award for reconstruction of mandible by vascularized fibular graft, state level conference, Pune, October 2003. Vidarbha level conference, Amravati, November 2003. Best paper award, parotid surgery workshop at Pune 2008. Best paper award, solitary parotid sarcoidosis, Pune 2009 November. All papers published in national and international journal of otolaryngology and head and neck surgery. Over to you, Dr. Netra Pathak ma'am.
Thank you everyone for the nice introduction. Good evening all the members of PSRDA, and once again thank you Kamini ma'am, Joshi ma'am for inviting me to have talk on this, as she said, a very common problem, that is the allergic rhinitis. So we all know that it is a global problem rather, which is seen in all the people of all the age groups as well as across all the countries. So the commonest problem, and why we have chosen this topic, that will come to know. I would like to share my screen and we'll discuss regarding its etiopathogenesis, it's how the patients they presents, and most important part of the today's talk will be its management. That is very important. How to manage this notorious disease, which is troubling not only the patient but also the consultants, because they keep on coming to us on a regular basis. Okay, can you see the screen?
Yes,
Is
ma'am.
it? Yes, and my voice is clear.
Yes. Audible.
Yeah, because I have to hear
Yes,
these
it is audible.
headphones actually.
Yes.
Okay. If there is any problem, let me know. Okay, while giving the
Yes,
talk.
yeah. Sure, ma'am.
Okay. So as I said, it's the commonest type of the chronic rhinitis, and it is basically because of the symptomatic inflammation of the nasal mucosa. Now, why this topic? Because allergic problem is such a common problem which affects, as I said, all the age groups, all the people. But the most important part is that it is not only produces the nasal and sinus symptoms. It is not limited to that part of the nose and sinus area, but it can have some impact on our routine lifestyle. It can disturb the sleep. It can cause a depression of the mood. It can depress our cognitive functions. It can impair the schooling in children as well as work in the offices. That is why it is said that it should be considered as a systemic disease and it should not be overlooked as a local disease. So that is why we have chosen this topic to know about its management. This allergic rhinitis, it has various other types also. The commonest one which we routinely see in our OPD basis in day-to-day consultations, it is a type 1 hypersensitivity reactions which is mediated by the Ig antibodies. So that is the commonest one, which is an allergic one. So similar to the allergic, there are some other non-allergic rhinitis also which are also seen in the community. We'll just go through what are those. Some are drug induced. We all know that the commonest are some antihypertensives which can cause a drug induced rhinitis. Then disturbances in the hormonal balance like hypothyroidism, rhinitis in pregnancy, then rhinitis of elderly patients, then occupational exposures to the dust that can also produce the rhinitis. Then gustatory, that along with the chewing or the mastication after the ingestion of the food, there is a production of the excessive nasal secretions leading to the rhinorrhea. So that is gustatory one. Then vasomotor, it is mainly because of the disturbances in our sympathetic parasympathetic nervous system. Then nasal mastitis and atrophic rhinitis. So though there are different types, but all in all the presentation is very much common. So it is a bit difficult to differentiate whether it is allergic or non-allergic. So we have to give some time for the history taking in our OPD basis. So we'll come to know whether it is really allergic one or it is a non-allergic one, because otherwise the symptoms are similar. Then most common what we see is a viral one, which is in because of the superadded infections by bacteria or fungal infections. Fungal infections, you must have heard about the mucormycosis in this COVID pandemic. So most of the patient having upper respiratory infections in COVID pandemic, and those patients who received steroids, they had mucormycosis, and again coming to the ENT with continuous rhinorrhea and sneezing. So all in all, the presentation is same. On examination and history, we have to differentiate the different types so that we can manage them accordingly. See, this allergic rhinitis is a global problem, and the overall prevalence is about 10 to 25%. The most common disease in childhood, reaching up to 40% in some of the regions. So a lot of prevalence is there in the community. This allergic rhinitis, itself, it causes about 50% of all the allergies, right? Allergies of eyes, allergies of the skin. So apart from the other allergies, the 55% contribution is only from the nasal mucosa causing the rhinorrhea. In India, 1 out of 6 people, they have allergic rhinitis. So that much prevalence is there. So as I said, it has impact on the lifestyle. That is why we have to consider this disease seriously. So what it causes mostly the trouble in sleeping at night, then loss of working days, then loss of days from the absentees from the school in cases of children, and most important, medication cost. Because as it is allergic in nature, we all know that when the disease is having a infective origin, viral or a bacterial, if we give antibiotic for few days, the disease comes under control. But as it is allergic in origin, the treatment duration is also more, as well as it also costs to the patients. So that is why we have to consider it seriously. If not treated, what can happen? This allergic rhinitis is mainly responsible for various complications. The commonest one is the asthma. We'll see what is the relation between asthma and allergy in further slides. Then other one is a sinusitis. Yes, recurrent rhinitis, stagnation of secretion in sinus will cause sinusitis. So patient coming to you with rhinorrhea, they also will have a headache. Then if it is not treated in time, if nasal secretions are there for longer duration, not received proper treatment, there may be the formation of polyposis. So bilateral ethmoidal polyposis, again a very common entity in our ENT OPD. So actually, frankly speaking, 50 to 60% of our ENT OPDs, the patients, they have allergic problems. Maybe most common is nose and sinuses, others from throat, larynx, as well as the ear. We get 50 to 60% population having allergic problems. So among that, nasal polyposis is also very common. Then next, which is also a commonest entity because of the recurrent rhinitis, is a otitis media. So that is an infection of your middle ear. Initially, patient complains of only pain, but as the rhinitis it goes on, there is a collection of the fluid in the ear, and later on it comes out by causing a perforation in the tympanic membrane. So it can cause complications of ear in the form of otitis media. So that is why we should treat it properly. Otherwise, these complications can occur. And there is the upper respiratory infection. Yes, if the so much of nasal mucosa which is inflamed is there, it is going to cause rhinitis, recurrent rhinitis rather than recurrent sinusitis. All those secretions, they will come down to the throat in the form of postnasal drip that will produce a granular pharyngitis, tonsillitis. In children, again, it can cause inflammation of adenoids that causes mouth breathing, snoring. So these all upper respiratory problems, they are mainly because of this rhinitis, and that is why its management is very important to avoid all these complications. So this allergic rhinitis is one of the risk factor for the asthma and uncontrolled moderate to severe allergic rhinitis, which affects the asthma control. So according to the one survey, that out of this 20 to 30 population which suffers from the allergic rhinitis, 15% patients that develop asthma. So that much association is there between the allergy and the asthma. And the large number of cross-sectional studies, they have demonstrated that the nasal symptoms, they are seen in 28 to 70% of patients having asthma. So allergic rhinitis patients having asthma and asthma patients having allergic rhinitis, there is a close association between these two entities. So that is why allergic rhinitis, if we treat properly, we can avoid the asthma, which is nothing but the allergy of lungs. Now coming to the risk factors, what are the risk factors for this allergic rhinitis? One is a genetic susceptibility. If one parent suffers from the allergic rhinitis, there are 20% chance that the children, they will develop the allergic rhinitis. And if the both parents, they are having allergic rhinitis, there are high chances up to 47% that the children will develop the allergic rhinitis. So it runs in the family. So in history taking, it is very important that we have to ask about the family history of having asthma or atopy or urticaria or the allergic rhinitis. Then most common cause or the risk factor is nothing but our environmental pollution. So nowadays, because of the excessive pollution, this problem is also increased across the world. So pollution, climate interactions, then continuous changes in the climate, which is very common in our Pune. Not a single day the temperature is same. There are continuous variations, and that is also responsible for the allergic problems. As I practice in Nare, most of the patients, they complain that whenever they were outside the Nare area or outside the Pune, this problem was not there. Once they have entered this Nare area, there is a lot of problem with the allergic rhinitis, and then mainly because of the pollution, continuous construction work is going on. So that is why a lot of dust is also there, and which is responsible for the allergy problems. Then various irritants like fumes, tobacco smoke, diesel exhaust, mosquito repellent, perfumes, scent sticks like dhoop or agarbattis, then perfumes what we use, then domestic sprays which use for pest control, and bleachers. All these are the irritant factors, and they're very common for allergic rhinitis. Then others are seasonal variations, and depending on the perennial one, that is the allergic rhinitis, which is seen throughout the year. The allergens are pollens, fungus, dust mites, domestic pests, and cockroaches. These are all the risk factors for development of the allergic rhinitis. Why we want to know about the risk factors? Because as I said, this is a notorious disease. It is not that giving the drugs or the sprays for one time and it will cure the disease completely. No, it is not like that. It is mainly what we can say, to treat it completely from the root cause. It is better to avoid the allergens if it is possible. So that is why we should be aware about all the different allergens which are responsible for this type of rhinitis, and out of that we can think of whether we can we means our patient, if we educate them properly, whether they can avoid these allergens so that their problem will be cured. Then there are two types of hypotheses actually they are given for allergic rhinitis. One is a worm theory and other is a germ theory. You must be knowing about the worm infestation. That is nothing but the parasitic infections they can cause in children. That is very common. That is why we do the deworming of children every 6 months. Parasitic infections, they cause a rise in our allergic cells, that is eosinophils, leading to eosinophilia, and that can cause allergic rhinitis. And other theory is a germ theory. According to theory, that if we expose our children to the germs in the initial phases, they can develop the immunity. That immunity can mature, and there will be a decrease in the allergic symptoms. But because of the hygiene and excessive awareness about the cleanliness, keeping hygiene to that extent, it can avoid or it can basically delays the maturation of immunity. And that is why the people where there is a lot of hygiene maintenance is there, cleanliness is there, those patients or their children, they have a higher chances of developing the allergic rhinitis. So let the immunity matures early so that we can avoid the allergic problems later on. So lack of immune maturation in infancy leads to the allergic responses. So this is germ and worm theories there. So pathogenesis, you all know about it, but we'll just go through the slides. What is that? So whenever this allergen is inhaled, of course, it will come in contact with the nasal mucosa. In the nasal mucosa, there are macrophages. They carry this allergen to this lymph node actually, where there is a presence of T and B cells. So it interacts with the T and B cells that produces these IgE antibodies. And these IgE antibodies, they get attached to the mast cells. So, and a repeated exposure to the allergens, what will happen? There will be a degranulation of this mast cell. And once these mast cells, they get destabilized, they release some kinds of chemicals. So like histamines, you must be knowing about antihistaminics. So why we give antihistamines? Because we have to combat with the histamine reaction. Then for anti-leukotrienes, for this leukotrienes. So histamine, leukotrienes, prostaglandins, these are some chemicals which are released on the degranulation of mast cells. And these are the mediators which produces this early phase reaction. So when the patient says that whenever the allergen comes in contact, within half an hour, I develop having a itching, sneezing, rhinorrhea, and nasal congestion. So this is the early phase of the reaction or the symptoms produced by this type of chemicals. So what we have to do? We have to treat them by giving all the antagonists which will act against these chemical mediators. Then if after this degranulation, if there is a cellular infiltration of these mast cells with the eosinophils, neutrophils, monocytes, and the basophils, that will produce the late phase reaction, that is a delayed development after 8 or 10 hours of the exposure to the allergen. So what are the symptoms of such patients? It is mainly the stuffiness of the nose. There is a edema of the nasal mucosa causing nasal congestion, then nasal hypersensitivity, and of course the rhinorrhea will be there. So nasal blockade will be the main symptom, and the secretion. In this, the secretions, they are watery. पाण्यासारखी सर्दी गळते, टप टप पाणी गळतं. This is the commonest symptom what the patient tell. In late phase, there is a thick purulent discharge. So this is the difference between early and late phase. So history and examination both will give us the idea whether your patient is having this type of problem, that is early phase, which is caused by this, and delayed because of the infiltration of the cells. So accordingly, we can choose the line of management. So just now I have said about the early phase, that is 5 to 30 minutes after the antigen exposure. There is a release of inflammatory mediators, and how the patient presents with the runny nose, nasal blockage, sneezing, and itching. So most common is watery rhinorrhea, excessive sneezing, itching not only in the nose but also in throat, over the palate, eyes, and pharyngeal area, and sometimes in the ears also. So it is lot of nasal and other parts irritation is there. In delayed one, it occurs after 2 to 8 hours of antigen exposures and infiltration of these cells. And we have just discussed the patient, they present with the nasal blockade and sneezing and itching. These are the complaints which are less in the late phase. So these are the commonest complaints: runny nose, blocking of the nose, sneezing, and itching. These are few signs from the just external examination of the, whenever the patient comes to our chamber only, by looking at the face of the nose of the patient, we can calculate that yes, the patient is having allergic problems, like continuous rubbing, upward rubbing of the nose, producing this. There is a crease over the dorsum of the nose. This is allergic solute, or this allergic crease over the nasal dorsum. Then on examination of the nose, we can see the turbinates. Most of the time, patient himself complains that there is a huge mass inside the nose, or something is there which is blocking the nose. So on examination, what we see, just by tilting the tip of the nose, we can see the inferior turbinates. So what is the position in the allergic rhinitis? They are swollen, they are edematous, they are purplish or bluish in nature, and lot of secretion around it. So along with the nasal symptoms, the other parts of the body, they are also affected. There is you must have seen such patients having the dark circles around the eyes, that is called as the allergic shiners. Then if you examine the eyes, conjunctiva is congested, there is increased lacrimation, continuous EP4 is there. Then eustachian tube blockage will produce oral fullness, कान गच्च वाटतात, बंद वाटतात, पॅक झाल्यासारखे वाटतात. This is the common complaint about the ear. Then because of the throat involvement, chronic pharyngitis, if you examine the throat, you can see granulations over the posterior pharyngeal wall. There also you can see a postnasal drip of the secretions also. And once this condition happens, it can produce edema of the vocal cord. So patient will also tell you that there is a change of voice. Either it is a hoarse voice, or it is a flat voice, or a potato voice, what we call, because of the involvement of the vocal cord. So this is the allergic rhinitis, starts from the nasal mucosa at its anterior part, and it can go up to the larynx. So there are two types of allergic rhinitis actually. Seasonal means in a particular climate or a season, patient will complain of nasal discharge and conjunctivitis. And while the perennial means, which is throughout the year, patient can have a perennial rhinitis in the form of nasal blockage. Hyposmia means loss of smell, decreased smell. Again, that is the commonest complaint the patient will have because of the recurrent rhinitis and sinusitis. Sneezing will be less, nasal discharge will be thick, purulent, and patient may have a conjunctivitis and eye symptoms in the form of itching. There is one classification, that ARI, you must have heard about area, that is allergic rhinitis and its impact on asthma classification. So depending on the duration of the symptoms, it is divided into two parts, intermittent and persistent. If it is less than 4 days per week or less than 4 weeks, it is an intermittent one, and persistent means more than 4 days, more than 4 weeks. So this is mainly seen in different climate changes or the seasonal type of rhinitis. Persistent in cases of vasomotor rhinitis or the perennial rhinitis, persistent symptoms are there. Again, we can divide the symptoms of patient into the two categories, whether it is a mild one and whether it is a moderate to severe one. Mild means patient will only have a runny nose, but it will not disturb the sleep of the patient, his daily activities, his working as in children, their school life, it will not be disturbed, and no other troublesome symptoms in the form of snoring or mouth breathing will be there. If it is a moderate to severe, patient will have disturbances in the sleep, may have a sleep apnea also because of the nasal blockade. Patient may feel sometimes dizziness because of the continuous blockage of the nose and the sinuses. Apnea, sleep apnea may happen because of the constant nasal blockage. So mouth breathing, snoring will be there. Then there will be impairment of daily activities, sports, and leisure. Then problems caused at school or work and other troublesome symptoms. So moderate to severe type of allergic rhinitis, they tend to develop the asthma also. So this is again a classification, and again this classification is given from the management point of view, how to manage the patient. We have just seen what are the common these allergens. In seasonal rhinitis, it is mainly the pollens. So tree pollens, grass, weeds, then molds, which are spores, which in outdoors they have seasonal variations, which are reduced in winter and they are increased in summer. And it is decreased mainly because of the humidity, it will be less. So pollens, mold, house dust mites, they are mainly responsible for seasonal type of allergic rhinitis. Then in perennial one, they are fungi or the mold. Then pets like cats and dogs, house dust mites, and the cockroaches. These are common allergic agents for the perennial type of the rhinitis. Now coming to the management point of the view, allergic rhinitis, first important is the history taking. As I said, we want to know whether it is allergic, non-allergic, whether it is seasonal, whether it is perennial, whether it is intermittent or it is constant there throughout the year, and what are the symptoms, whether they are mild one or they are causing disturbances in their day-to-day activities. So in history, that much history you have to ask. Family history is also very important. Then whether patient has taken any other medications for the same, that you have to see in the history. So general medical history, family history, various nasal symptoms, then frequency of the symptoms, daily, episodic, seasonal or allergic, medications as I said. Then what type of the discharge? If it is a clear watery, patient only tell you that it is पाण्यासारखी सर्दी, so it is a clearly allergic rhinitis. Thick, purulent, it goes in favor with the bacterial rhinosinusitis. If it is a chronic one, of course it will be purulent, there will be a foul smell and there will be a constant headache. So these are the important points from the history. Then various tests what we do. The physical examination, as I said, allergic salute, allergic shiners, crease over the dorsum of the nose, pale turbinates, edematous mucosa, then black circles around the eyes. These are the common pictures. Or in cases of throat having a chronic pharyngitis, that is a granular pharyngitis, that are the points we will see on examination. Now, the next point is its diagnosis, how to diagnose. Actually, so many tests are there. You must also be treating these patients. So we do not go for all these tests because they are very expensive and we do not get a perfect outcome from that. Yes, my patient is allergic to this one, only one allergen, I can avoid it and patient will be all right. No, not like that. All these tests, they give a rough idea about allergy and they show that your patient is allergic to so many allergens. It is said that right from earth to sun, whatever comes in between, everything your patient is allergic. So that is not possible to avoid. So one can go for that. If patient insists, I want to find out, you can go for a skin prick test, which is a cheaper one. We just see what we do. Yes. Intradermally or in a subcutaneous layer, this it is inoculated, allergy is inoculated, and we have to note the reaction. So it is a rapid, efficient, and cost-effective one. Multiple antigens we have to test at so many places. As I said, yes, it is cheap, it is immediate, it is sensitive, but it can produce various anaphylactic reactions also. And if the patient is having a previous history, it should be contraindicated. Such type of blebs, they are produced on the skin while testing the various allergens. Another test what we can do is in vitro test of the IgE antibody titers, that we can measure whether they are raised. Again, it is a costly affair to measure the IgE antibodies. So in our OPD basis, what we do apart from going for the skin prick test or this RAS, that is a radio allergo observant test or in vitro test, we simple do absolute eosinophil counts and the hemogram. We just get a rough idea whether the eosinophil count is raised or the eosinophils from your DLC, it is raised. That will get the idea. And if it is raised, accordingly, we can treat that. Second thing is doing the nasal endoscopy in OPD basis. We come to know, we can examine complete nasal cavities on both the side. We can see the status of the turbinates, septum, as well as the sinuses. So that idea also we get from the nasal cavities. If too much of secretions are there, we can take a nasal swab also to find out the eosinophils in that mucosa. Other thing, if you suspect the patient is having a recurrent attacks of the rhinitis causing sinusitis, so this is a CT scan. We go for a CT scan of paranasal sinuses. So that gives the idea. So in this patient, yes, because of the recurrent rhinitis, this patient has sinusitis also. So that idea we get from the CT scan. If the patient is having a nasal polyposis, chronic sinusitis, so those patients, they need a surgical treatment also. So in such cases, we advise CT scan. Not each and every case of allergic rhinitis need any radiological investigation like a X-ray or a CT scan. It should be indicated only the patient is having a chronic symptoms. And if you think of sinusitis, polyposis, or any other nasal mass in an elderly patient, and in COVID pandemic, the most hot topic was mucormycosis. So if you suspect such type of entity, yes, we have to do the CT scan. In mucor, we have to do MRI also. So this is again one of the endoscopic picture of the patient where we can see the polyps in the nasal cavity. So if you see such type of pathogenesis, there is a role of CT scan. Otherwise, there is no role of radiology in plain allergic rhinitis. These are other types of rhinitis. They should be considered whenever you are treating the patients. If patient is not getting relief from the routine management of allergic rhinitis, we can think of vasomotor rhinitis, we can think of polyposis. Then one more entity is there. There is a turbinate hypertrophy of inferior turbinates because of the chronic use of nasal drops in the form of xylometazoline or oxymetazoline. So constant nasal blockade will be there and rhinitis sneezing will be there. Then hormonal rhinitis and CSF leak. CSF leak, it may be seen spontaneously where the patient, there is a sudden rise of blood pressure or any history of nasofacial trauma is there. So this CSF, it also looks like your routine nasal secretions. So, but it is mostly it is a unilateral one. And if patient says that yes, there is a unilateral nasal discharge on bending down basically, and bit pinkish fluid it is coming constantly from the nose along with the headache, you can think of this entity also. So this definitely needs CT scan and MRI, and of course the examination of that nasal fluid, whether it is these are just a nasal secretion or it is a CSF. For that you have to collect that fluid and send to the pathology lab to find out whether it is a CSF or it is just a fluid from allergic rhinitis. So all these entities you should keep in mind while treating the patients of allergic rhinitis if they are coming to you chronically and not getting the relief. So this is just a picture showing what the children of 90s used to do and what the children of this era they are going through. Now coming to the management of the allergic rhinitis. So initially only I said our focus should be on these 2 points. First is avoid those allergens if possible, if it is practical one, and second is educating the patients about various allergens and teaching them how to avoid them. Next is nasal douching, medical therapy, immunotherapy, and surgery. Will go one by one. So these are the globally important allergens: house dust mites, grass, tree, weed, pollen, pests, cockroaches, molds. So these are all, if it is possible, yes, we can remove them. We can do the pest controlling also. So if it is possible, we can avoid the irritants like smoke, dust, or vehicle. That is very less likely to avoid. But if it is possible, yes, because of the COVID, everybody is starting using the mask, and of course there is a decrease in patients' symptoms also because of use of the mask. So that is the advantage of mask. So we can ask the patients of asthma and allergic rhinitis wear a mask where they are whenever they are outside the home. Then in home, what are the factors that we can avoid? We can remove all these dust. First is the dust control, then removal of the pets, use of the mask, encasing the pillows and the bed sheet by using a plastic covers, and regular use of a vacuum cleaners. These are the few common measures that can be advised to your patient. They can be educated regarding these factors. Removal of the pets, again most important, you have to take the history whether they have a cat or dogs at home. They should be removed from the bedroom or wash them weekly, keep them clean. Then mattress should be covered. Yes, they should be changed on the regular basis. These are all the points we have just discussed. So most important, educate the patients on the environmental control measures that involves avoiding the known allergens and avoidance of a non-specific or irritants or the triggers. Means they can reduce the use of perfumes or deos. They can stop धूप आणि अगरबत्ती जे आपण देवापुढे लावतो. They can stop doing that also. That is also one of the commonest factor which is responsible for the allergic rhinitis. And most of the time air conditioner, it itself also one of the commonest factor which is seen for allergic rhinitis in IT people. So if possible, they can change the place, they can shift to the non-AC areas. And if it is not possible and too much of symptoms and troubles are there, then they can think of changing the job also, because there is no other solution rather than shifting to the other areas. So air conditioner is also one of the commonest factor for allergic rhinitis. Now coming to the management, the next point is a nasal douching. Yes, you must have seen again in this COVID India, this neti, actually it is an ancient one, but now it has got a lot of popularity during the COVID pandemic by doing the irrigation of the nasal cavities. So neti, jalaneti, it has a definitely role in all our allergic problems, in problems of nasal sinusitis also. It removes the debris or the excessive stagnated secretions, not only from the nose and the sinuses, so that will improve the mucociliary function of the nasal mucosa. Once that function comes to the normal, automatically the allergic problems are reduced. So jalaneti, yes, it has a very important role in allergic rhinitis. Now coming to the medical management, again we have to divide the symptoms patient into mild, moderate and severe, and accordingly we have to treat them. So mainstay of the treatment is antihistaminics. You must be already prescribing all those antihistaminics. There are type H1, H2, both are there. This basic one, actually Avir or cetirizine, we try to avoid because they cause a lot of sedation, and so that is a first generation what we call antihistaminics. We try to avoid because of the safety, because all our patients, they are working, they travel, so they should not have a dizziness or a giddiness because of the first generations. We try to avoid them. But the control is very good with the first generations, but the symptoms again they occur frequently. So what we prefer, they're the non-sedative one in the form of second generations that you all know, that is a fexofenadine, one of the drug choice for the treatment of mild to moderate symptoms. Then next in that category, this oral or local or topical antihistamines, then is a rows of decongestants. Because of the nasal edema, there is a lot of nasal congestion causing a nasal blockade. So we have to give the decongestant in the form of xylometazoline nasal drops. Again, we have to remember that entity, that is a rhinitis medicamentosa. So this use, it should be limited to less than 10 days. Otherwise, it will produce the rebound congestion of the nose, and that it becomes actually permanent. So later on, no drops, they work in the resistant cases. We can also think of oral decongestants in the form of pseudoephedrine, phenylpropanolol, that also decongest the nasal mucosa. Then, as already discussed about the education and allergic avoidance, yes, it is the important one. We have to counsel the patient regarding things first before going for the drug treatment. Then, as I said, what is the basic pathogenesis? It is a degranulation of the mast cells. So what we need, because of that degranulation only, there is a release of chemicals, and those chemicals, they are responsible for symptoms. So what is our aim? To stabilize those mast cells. So for that, the drug of choice is sodium chromoglycate, not very commonly used, but yes, it is available in the form of 2% sprays, and that can be used. And the drug of another choice after this antihistaminics comes the role of steroids, highly effective one. Again, oral, topical, both we use for the patient depending on the severity of the symptoms. As far as possible, we should try to limit our treatment to the intranasal one, that is a topical one in the form of sprays, because very less side effects are there. Side effects are there, but they are just in the form of either atrophy or septal perforation. And oral one, you know all what it can cause, oral or IV. There is a disturbances in the sugar levels, and in this again the COVID, that was the main cause, giving IV and oral steroids without monitoring the sugar levels, which was responsible for mucormycosis. So fungal infections of the nose you should keep in a mind while treating the patient with the steroids. So limit use to the topical one. In severe cases, having asthma and all those, yes, we have to give them orally. In oral also nowadays, instead of using directly the methylprednisolone or omnacotil, there are some few newer steroids which are bit safe, that can be given for limited duration. They are a deflazacort, so that can be given for a limited period. So these are the mainstays of the treatment. If all these treatments they fail, then comes the role of immunotherapy and surgery. Just see, these all sides we have already discussed what we give for our patients. Ipratropium bromide spray, that is anticholinergic, to reduce the secretion. That spray is also available, but we do not commonly use the ipratropium bromide sprays. Then other is the antagonist of your leukotrienes, that is called as a anti-leukotrienes. Again, you must all be aware of this molecule, that is a montelukast. It is used in almost all the patients having a rhinitis, and it has a very good results also. So it again, the monotherapy has no role as such. It should be given in a combination along with the antihistaminic, that is a that is fexofenadine. So that combination again, it is it works better for all your symptoms of the patients of allergic rhinitis. So montelukast and fexofenadine is a preferred one amongst the other. Now, immunotherapy, when all these medical therapy measures, they fail to cure your patient or control the symptoms, then comes the role of immunotherapy, but it's a very costly affair, and treatment, it lasts from 1 year to few years. So who are the candidates who should be given this immunotherapy? Whenever there is inability to avoid the allergen, inadequacy of the drug treatment, and most important, the affordability. Patient is affordable and ready to wait for 3 to 4 years for the treatment. The patient should be included in the immunotherapy. And these are the contraindications for immunotherapy. Pregnancy, small children, patients having asthma, beta blockers, we avoid. Actually, what is done in immunotherapy, again, that allergen is given in a aqueous solution, in a subcutaneous layers, in an increasing basis. So dose is gradually increased till the maintenance is reached. And later on, whenever this allergen it comes in contact with that allergen, whatever the antibodies they are formed, it will not produce the symptoms. So that is the main role of the immunotherapy. But it is very costly, so it's the role is very, very limited. Then coming to the surgery, what are the candidates when we advise the surgery? Of course, the allergic rhinitis is not the entity which is indicated in surgical part. What are the treatments? If the patient is having a grossly deviated septum, if patient having a chronic sinus problem, if polyps are there, if turbinates are hypertrophied causing a nasal obstruction, if patient having additional tonsillitis, adenoids, those are the patients where we can do the correct all the comorbid conditions by doing the surgery. It will clear the mechanical obstructions actually. If you remove the polyps from the nose, if you correct the septum, yes, his nasal ventilation, nasal passage will be cleared. So that will of course increase the ventilation in the nose and the paranasal sinuses, and increasing the ventilation, the nasal mucosa will come to the normal and patient symptoms will reduce. But pure allergic rhinitis is not the indication for the surgery, because as we know this, it is mainly because of the rise in the IgE titers, raised eosinophils in the blood. They are mainly responsible for the symptoms of the patients. So they will be treated by giving a topical medical management only. And these are the few indications for surgery. Then other some factors are also there from the other pathies like honey. It has some role for controlling the pollens in allergic rhinitis. It can be given. The Chinese herbal medicines, they are also available. Acupuncture, some other treatment modalities they are given for the allergic rhinitis. Similarly, as I said, this when we compare adult and the children, in children also there is a rise in allergic rhinitis cases. So what is the drug of choice? Mometasone, fluticasone, they can be given above the level of 2 years of the age. Mainly what we give, we try to cure by giving the sprays instead of giving the oral one. But excessive symptoms are there. Yes, we can give the Montelukast fexofenadine in combination in the form of tablets or the syrups for the limited period. Otherwise, we can control by giving a mometasone and fluticasone. And most important in children is the we have to educate the parents for deworming. That deworming should be done by giving albendazole or mebendazole every 6 months, so that will control the parasitic infections, that will prevent the eosinophilia, and automatically the symptoms will be reduced. So that is about allergic rhinitis in children. In pregnancy, of course, there is a fluid retention, there is a vasodilatation. So whatever the nasal and sinus symptoms are there, they get aggravated during the pregnancy, and it is such a crucial period. We cannot give our steroids and other drugs to the patient. So what are the drug of choice? What more safety is the chlorpheniramine, loratadine, or cetirizine. So among the cetirizine is very safe in pregnancy. It can be given, and of course the topical nasal decongestant in the form of xylometazoline drops, as well as the steroidal nasal spray. They can be given to your pregnant patients. Of course, immunotherapy is contraindicated. If the patient is having history of asthma also, then of course this inhalers, it is the rotahilar, it is given for asthma. Similarly, you have to use the intranasal steroids. Oral steroid can also be preferred in the form of deflazacort. And of course, the Montelukast, it is a drug of choice for patient having asthma in addition to the allergic rhinitis. So these are the fewer special categories while treating the patients of allergic rhinitis. So again comes the role of history is very important. Then fewer some recent advances are also there, like in the drug available in the form of this human monoclonal antibody, that is anti-IgE. This is a type 1 hypersensitivity reaction, actually, what we are discussing, where this IgE titers are raised. So anti-IgE drug, that is omalizumab. So it is one of the recent development, but again, it's a very costly affair. Under trials, they are going on. So definitive, whether it is really helpful or not, that has not yet confirmed. So this, but it is a drug of choice, or we can see further hope is there in after having this Montelukast fexofenadine. Nowadays, again, another molecule is there in the market, that is a bilastine. Again, it is, they have combined with the Montelukast. Added advantage is that it is non-sedative. So that was all about the allergic rhinitis. What are the common agents, how the patient present, how to differentiate the two types, and what are the different categories of the patients, different types of the symptoms, and what are the different modalities, what are the things we should consider in the management. Just by giving the nasal drop or spray, it will not cure the disease. You have to think of what are the basic allergens, and accordingly you have to treat them. So just to conclude my talk, I will say it's a very common disease, having a considerable morbidity in the form of ear infections, sinus infections, laryngitis, and most important, the asthma. Then adequate and appropriate treatment, it is to the significant improvement in quality of life. Yes, definitely it will improve. It has a perfect impact. If we give the treatment, it will not cause the sleep disturbances, and it will not hamper the work or a schooling in children. Then comorbid conditions, they are common, and they warrant a special attention and treatment of optimal result, that just we have discussed. And environmental manipulations, it has an important role in the control of disease. So most important is the control of the pollution. It should be there. Lesser use of this diesel and then industrial pollutions, though it is not in a hand, but if it is controlled to some extent, these allergic problems will be definitely reduced. And this allergic rhinitis, it will not be responsible for disturbing the life of patient, causing various comorbid conditions. So that was all from my side. If you have any queries or any problems, whatever you must be facing in your day-to-day OPD or day-to-day patient or something else, if you want to know about this, you can ask me. Thank you so much.
Ma'am, one more question. Hello.
Yes, I can hear.
Yes. How long treatment given in chronic AR?
Again, I said chronically we can give these steroid nasal sprays. They can be safely used up to 3 months. But if we think of giving the oral medications, this use should be limited to 1 or 2 weeks, not more than 3 weeks. It should go. Otherwise, you have to monitor the on regular basis patient's hemogram as well as the sugar levels. That is very important. And of course, the patient's age also matters. If the patient is already having your diabetes, blood pressure, or any chronic diseases, we have to think of the other factors also. Those drugs, they should not be given, which will again impair their function of the kidney and the liver.
And how long fexofenadine and montelukast?
The same one, as I said, yes. How I treat the patient, it is same one. Initially, you have to give for 5 to 7 days only. Look for the response, whether your patient is really getting a benefit or no. If yes, another 2 weeks you can continue, then you have to stop it. There should be a gap. It should not be in a continuous use. Otherwise, it becomes resistant, and patient will do not get the benefit. Any other thing you see in your patients, in allergy problems, patient coming to you, any other associated other complaints or anything else apart from ear, nose, throat only? Hello, Kamini madam, can you hear me?
Yes.
Any other thing you want to know? Yes.
Already you have explained all aspects of the allergic rhinitis, ma'am.
They see it is a very actually common entity. Everybody treats. It is not the ENT only who is treating the allergic rhinitis. It is from the general practitioner, from the physician, everybody. The patient comes in contact. Only thing is that when to consult the ENT is also again the very important fact, as I mentioned in the complications. Because all these nasal problems, the sinus and all those, they start with the rhinitis only. So treating the rhinitis to some extent at your level, yes, it is very yes, that is recommended. But if you think of sinusitis and going in formation of the polyps or any nasal mass, because you must be aware about the various sinus malignancy. These maxillary sinus carcinomas, they are very common in our country. Okay, and what is the cause? It is not every time the industrial exposure or wood dust or a furniture. No, it is the chronic rhinitis which is not treated in time. That continuous rhinitis, and what happens in chronic sinusitis? There is change in the nasal mucosa. Okay, there is a metaplasia of that epithelium, and then it forms the it goes in favor of formation of malignancy. So that is why this is the simplest rhinitis. It can turn into the malignancy. And again, in malignancy also such types of variants are there, right from the squamous cell or adenocarcinomas. For few cancer treatment is there, but angioinvasive adenocarcinomas and all those, they are not treatable. The prognosis is very bad. So even if you do the maxillectomy or give some radiotherapy, it has no use. So it is better to diagnose at your stage and then refer to the particular, it may be oncosurgeon also if you think of that malignancy. So while treating the simple rhinitis or allergic rhinitis, all these entities should also be considered.
Yes, ma'am.
And another was this mucormycosis. Yeah, again, the patients of COVID having the upper respiratory infections, almost 50 to 60 patients what we have operated in last 4 months, more than that rather. So in maximum, more than 50 to 60% out of that patient, what was the history? That those patients, they had a chronic rhinitis, sinusitis, allergic problems were there. And those patients, they developed COVID, they were given steroids in a random way. And those were the patients who succumbed to the mucormycosis. So again, the rhinitis was the basic pathology for developing the mucor.
Okay. There is no more question, ma'am. Yes. Thank you, ma'am.
Thank you so much, actually. Yes, I would like to also say thank you to you and Kamini madam and PSRDA Association, as well as Gigi, for inviting me and giving a talk. Okay, thank you so much.
Thank you, ma'am. You have taken very nice session for us.
Thank you, Netra Pathak ma'am. You have explained all aspects of the allergic rhinitis, such a difficult topic in a fluent language. Thank you, ma'am, enhancing our knowledge. Thank you very much. Thank you, Corona Remedies, our today's sponsor, and Dr. Lohekar sir and Dr. Nikhil Deshmukh sir for all your efforts. They had very special efforts for this lecture. Thank you, PSRDA organizer committee. Thank you, DigiShield, and thank you, Mr. Piyush sir. Thank you very much. Thank you all my friends.